enters the
corneal cross-linking shall we do? And
yes,
then after
sir.
That
We'll go ahead with the cross-linking. Yes, sir. So he will be talking about the recent updates in corneal cross-linking. So,
Okay, thank you, Dr. Mamta. I'll be talking about what are the recent updates that have come up in corneal cross-linking. We know that corneal cross-linking is an established modality these days for stabilizing the cone in keratoconus. And it is usually done in progressive keratoconus. So these are some of the evidences of progressive keratoconus. Since there are many factors involved in it, so there was a global consensus that was done on the criteria that should be included for this thing, for progressiveness of keratoconus, and that is progressive steepening of anterior corneal surface, posterior corneal surface, and progressive thinning. And if it is, if there is a progressive keratoconus, in that case, corneal cross-linking is the standard modality, which is an established modality these days for stabilizing the cone in keratoconus. So, in a standard technique, the Dresden protocol, what you do, you debride the central 7 mm of epithelium, then you put riboflavin every 2 minutes for 30 minutes. And then after that you focus the UV rays for 30 minutes and you keep putting riboflavin again for 30 minutes. So it's a 1 hour duration treatment modality, and it is quite effective. There are many studies, various studies now have shown the effect of corneal cross-linking, and it is shown by the presence of a demarcation line. And as you can see here, demarcation line is seen at almost 2/3 of the thickness of the cornea. And that's why it is said that cross-linking works mostly in anterior 2/3 of the cornea. And that is why in post-LASIK ectasia, it is not a very great modality, because since it works in anterior 2/3 of cornea, and almost 150, around 140, 150 microns of the anterior cornea is made by flap of the LASIK, and it is known that flap does not contribute to the strength of the cornea, and that is why it is said that post-LASIK ectasia may not be the best cases. The primary keratoconus has better, the effect of cross-linking is better in primary keratoconus than in post-LASIK ectasia. Then various procedures have been combined with it, which is called CXL plus, like you can use PRK, ICRS, like ring segments, and toric ICL for this. Now, when you do PRK and cross-linking in keratoconus, the idea is to not to correct the refractive error, but to just to smoothen the surface, to reduce the irregularity, so that the patient can be fitted contact lens, the contact lens fit can be good, and the patient can be rehabilitated. Again, as far as intracorneal ring segment is concerned, the idea is to reduce the astigmatism and then do cross-linking. So that is why many times these days we put asymmetric segments, because in most of the keratoconus cases the astigmatism is high, so asymmetric segments are more useful than symmetric segments, because symmetric segments reduce the spherical power, asymmetric segments reduce the cylindrical power, and sometimes we use a single segment as well. So first of all, we open up the initial track after creating by femtosecond laser. You can do it with a mechanical separator as well, and then you put this PMMA ring into one pocket, and then you put another ring in another pocket, and then this radial incision is closed with a suture. And once you have done that, then you debride the epithelium within the ring segments and then do cross-linking of the cornea. So the idea is to remodel the corneal shape and then stiffen it by cross-linking. And studies have shown reasonably good results in these cases with the ring segments and cross-linking. So it is now an established modality. CXL is an established modality in keratoconus, but there are certain issues, and for which we keep doing various researches, various studies, and one of the issues is pain, because you debride the epithelium, nerve endings are exposed, so the patient has pain. The second issue is a long duration. Patient's cooperation for 1 hour is needed. And the third issue was if the cornea is thin, like if the cornea is thinner than 400 microns, the UV rays can have detrimental effect on the corneal endothelium. And based on that, various innovations have been tried like to reduce pain, the epithelium without debriding epithelium, transepithelial CXL has been done, but it has not been found to be as effective as conventional cross-linking. Then people tried various ways. These are various studies which have shown that EP-off has a better impact. Then there are various ways of doing. People have done crisscrossing of epithelial removal, so that some area will have will be denuded of epithelium and some area will have epithelium, but then it doesn't work because the area wherein the epithelium is intact, the demarcation line is not clearly visible. So this means that probably the effect is not there in that area. So the punchline is that currently, in order to have good efficacy of cross-linking, we have to debride the epithelium. Then regarding duration, many other protocols have come up in accelerated cross-linking, that is based on Bunsen-Roscoe law of reciprocity. So instead of 3 milliwatt per centimeter square for 30 minutes, various other protocols are there, 9 milliwatt per centimeter square, 18 milliwatt per centimeter square for 5 minutes, 30 milliwatt per centimeter square for 30 minutes. And we were very excited initially by doing 30 milliwatt per centimeter for 3 minutes. But now the studies have shown that the effect may not be as good with 30 milliwatt per centimeter square for 30 minutes. The effect of 9 milliwatt per centimeter square for 10 minutes is mostly comparable with the conventional cross-linking, and that is why as far as accelerated cross-linking is concerned, this protocol is followed. Then in thin corneas, people have tried hypoosmolar riboflavin so as to swell the cornea. The effect is there, but the effect is not that much because at on one hand you are separating the collagen lamellae by hydrating the stroma, and on the other hand by cross-linking you are trying to make it compact. So the effect is not that great, but yes, it has some impact in thin corneas. People have tried various other things like bandage contact lens, but bandage contact lens has a problem again. You do cross-linking, it works in anterior two-thirds of cornea. So what happens, part of it is discarded because bandage contact lens is removed. It is occupied by bandage contact lens. Another thing is that the tear film behind the bandage contact lens allows less penetration of corneal UV rays, and that's why the effect is not that great. Again, people have used smile stromal lenticules, but it has not been that effect. So we tried in RP center, we have done 2 studies actually. We created an intrastromal pocket and then introduced with a femtosecond laser, and then introduced stromal lamellae 200 microns created by a microkeratome with donor tissue. So here, after doing dissection, you inject riboflavin into the pocket. So the penetration of riboflavin on both sides of a stroma is quite fast. And then after that, you put a donor. This is the stromal lenticule that has been fashioned by a microkeratome, and that is introduced into the inside the corneal stroma. So once you have done it, then you do cross-linking, and that is how it is done. So day 1, the stromal lamellae swells up. I'll just finish in 1 minute. And in day 1 it swells up, but then later on the thickness reduces, and then you have a reasonably good effect. You can see here that the cornea is quite clear. The only thing is that it has 2 interfaces, so you have to give topical steroid for long, because initial cases when we did not give topical steroid for long, there was interface haze that was seen. So that is what this is. You can see here the nice topographic map after putting this lenticule. Actually, I did not go into details of lenticule. We create a negative meniscus lenticule by ablating the central part of the cornea. So it does have a sort of an intact kind of effect as well, because the peripheral part is thick and the central is thinner. And then another option that has come up now these days is customized cross-linking. The idea of putting more power in the area where there is, which is thinner and weaker, and lesser power in the peripheral area. Studies are on, but we are yet to be absolutely sure about its efficacy. Again, studies have shown that oxygen concentration reduces in the stroma when you do expose the cornea to UV rays. So people have done animal study using external source of oxygen by putting oxygen around the cornea. The animal studies had shown some good effect by Theocellular group, but we did a human study and we found out, I'll just skip this video, which we have created this indigenous goggles. This goggle costs about 3,000 euros, and this we created ourselves, and that costs 400 rupees. Actually, with this goggles, actually you can also measure the oxygen saturation, which we have tried. This is how we put oxygen from here. We measure the oxygen saturation from here. This is the open part through which the UV rays are focused, and on the anesthesia machine you can measure the oxygen saturation also. We maintained it at a level of 84% average, and that is how we did. But having said that, the results are not as gratifying as we had thought of, although there is some effect, definitely slightly better effect, but not that gratifying, and we are working on it more and longer follow-up is needed to see. So there are some queries raised by this, that whether oxygen saturation is directly related to the efficacy of cross-linking. Another paper has just now come with adaptive fluence by Farhad Hafizi group. It is again a questionable kind of a thing, because here even in a cornea as thin as 214 microns, he has done cross-linking, has shown good effect. Done cross-linking conventional method just for 2 minutes. There's a big question, many queries raised for this paper, whether it is as effective or not. So maybe with time we will be able to know more. So I won't go into details, and would like to conclude that cross-linking is an established modality, and various innovations have been done these days in order to improve the efficacy as well as acceptability of cross-linking. So thank you very much for your patient listening. Any comment or query, I'll be happy to answer. And if you allow, I'll...
Yes, sir.
Yeah.
Yes, sir. I will quickly, can I ask a quick question?
Yeah, please.
So considering we have so many machines, so many, brands of machine in the market, without considering the financial aspect, is there any particular one which you prefer, or you got good results with that?
We are doing with this Peshke one. So that is what, I don't have a comparative study, but this is one which has a good effect. So that's what we use.
So, Pescas,
yeah.
So, moving on with the next talk by Dr. Rajesh Sinha, sir. And
Please.
Sir, in below 400, as you said, there are a lot of patients who come with below 400 micron thickness. So, lenticle-assisted CXL or donor cornea-related CXL, any experience on?
Yeah, that's what I showed actually.
I think I missed that.
I had shown that if the thickness is less, instead of putting the lenticule over it, or instead of putting the bandage contact lens over it, if there is no scarring, in such a case we have used stromal lenticule. By creating a donor, from a donor tissue we created the stromal lenticule of 200 microns. And then it was implanted. Now initially when we used a 7mm lenticule. So the effect was not that great in some of the cases wherein the cone was of the larger size, and then the peripheral thick part was coming over the cone. What we did, we ablated the central part. So we made a negative meniscus lenticule, so as to have a ring segment like effect as well. And then we do cross-linking. It will have tectonic support, it increases thickness, it stiffens the cornea by cross-linking. You put riboflavin in the pocket, so there's diffusion of riboflavin also very well. So the result was good, but later on we increased the diameter of the lenticule to 8.5, and now we have completed that study, and we found that the effect of 8.5 lenticule is much better than the 7mm lenticule. And the pre and post-op, actually because of paucity of time I could not show all the results, but the pre and post-op picture, if you see, then the irregularity in the surface that is seen on pentacam before was in many of the cases it was neutralized. You will see an absolutely nice bow tie pattern. One picture I had shown of one post-op patient, very nice regular bow tie pattern after putting this 8.5mm lenticule and a negative meniscus lenticule with cross-linking.
I have one more question, sir.
Yeah.
If you have a pediatric patient of say 9, 10 or 11 years and he has a CCT of 350, so obviously we cannot go for AP off, considering we would be reducing it further. So what the options we have? Even with AP on, it would be lesser than 400.
Yeah, yeah. So in such case, yes, we can try. That's what I'm trying to standardize this procedure by just now. I have done 2 theses with 2 lenticule size, and now I am doing a 3rd ICMR project on this. In these cases only. So I'll have a longer follow-up and we'll be able to standardize the procedure.
But otherwise,
once we have been able to standardize the procedure, then we can do it in children who are having 350 microns, because it will not only increase the thickness of the cornea, it will stiffen the cornea, and then a good contact lens rehabilitation is possible. The child can be.
But right now what we have with that hypoosmolar is not a good option.
Hypoosmolar is not such a great option. In children, again, it is many times you have some VKC, etc. That also needs to be controlled. So hypoosmolar has a limited effect in primary keratoconus, in adults, in not in children. In children, again, the results may not be that great. So maybe, I haven't done in children the intrastromal lenticule, but maybe with time we will be in a position to, get with some, maybe it's a good idea we can do a children's study as well, doing this intrastromal lenticule. The only issue is that we need cooperation. It has to be done under general anesthesia. For creating the pocket also, we need a reasonable cooperation from the child. So that is something, a hindrance. Yeah.
The pockets were created with femtosecond laser?
With femtosecond laser. Initially we did with the Visumax, because we can create a 7.8 millimeter maximum pocket of 7.8 millimeter with Visumax. But then since we had to implant bigger size, so we went to FS200. We used FS200 to create a 9 millimeter pocket, and we implanted an 8.5 millimeter lenticule. So the second procedure that we have done now, just completed thesis, that is showing better results than the first one.
So docking in keratoconus was any issue? Docking in the keratoconus?
No, actually the minimum thickness that we have used is up to 330 microns. Docking is not at all an issue. Only thing is that there shouldn't be any scarring. We should avoid and the second thing is that any scarring in the donor stroma also should be avoided, because mostly we use a B grade tissue, non-optical grade tissue. So in one case there was thin stromal scar. I hoped that it will clear up, but it became more condensed, even if steroid. So a couple of adverse events are there, like one case had infection also, I had to remove the lenticule. A couple of adverse events are there, but most of the cases have shown good results. Only thing is long-term steroid is needed, otherwise there is interface haze.
So
see, DALC is a different procedure, this is a different procedure, so indication for DALC will be different. Like I can do a DALC in a case who has a 330 or 340 microns thickness with a superficial scarring. Any case with a superficial scar, I won't put a lenticule. Okay. So I will rather go for a DALC and then rehabilitate the patient subsequently with contact lens or whatever after removing sutures. So DALC can be done in cases wherein you have reducing thickness, 330, 250, lower cutoff. See, manual dissection you can do even up to 240, 250. But if you are doing a big bubble one, then it's better to use it. If you have a corneal thickness of more than 300, then it's better. Otherwise, anything below 280 will be dangerous.